暫時 so maybe we start in English. So I hope that in this 1 hour I can share with you a case and some common neurosurgical problems. So somehow I will just pretend to be the patient. So you can ask me some questions and do some history taking, and probably we can see which physical examination you want, and further on we'll discuss this case. So right now I think maybe you can throw questions to me and then I will try to answer you. So after that, one of you will summarize the problems for me, and then we can discuss on the examination and so on. So is it all right? So all right, maybe you can fire questions at me right now. Any questions? So to start the first question, I am a 52 years old man. Work in the logistic industry. Somehow I'm an office worker. So right now, what you want to ask me from?
What will be your any complaint? Any
Yes.
comfort?
Yes. Actually, I was admitted to the hospital 2 weeks ago, and maybe I just start the problems at that time. So on one day, actually, I have some twitching of my left hand. So all of a sudden, I have some twitching of the left hand, and after that twitching, I was very frightened. Somehow, after that, my left side is very weak, and I cannot stand. So that was why I was admitted to the hospital. 中文好啲喎，呢條 history。好啊，明白啊 ？OK 嚇。如果係咁嘅 twitching weakness，2個禮拜之前嚇。
係成個左邊手腳都 weak 嘅。
即係手差啲，腳都係差，因為開頭都係企唔到起身嘅嚇。其實當時都冇返緊工啦，咁喺 office 做緊嘢，咁啊都應該係10點零11點鐘啦，普通做嘢時間咯。
咁講嘢嗰方面有冇話口窒啊咁樣啊？
講嘢就清楚嘅嚇。維持咗1分鐘到啦嚇。嗱，啱啱抽完筋之後咧就好差嘅啲力，咁之後其實冇幾耐咧，我諗幾個鐘頭之後都好好多啦。不過唯獨是隻左手咧仲係好差啲力，我左手而家都仲係揸唔到拳頭啊，即係拎唔到嘢咯嚇。咁行去廁所嗰啲就行得到嘅。Okay, so any more questions, or you want to start the discussion at this point?
咁嗰陣時有冇話有頭暈頭痛呢啲咁樣嘅情況？
頭赤赤咁啦，其實呢輪都有啲㗎啦嚇，不過唔係好差咯嚇。咁我自己都唔覺得，即係我諗住冇乜事嘅嚇，咁少少唔舒服咁。呢個零月都係咁咯嚇。
咁嗰個頭痛咧，有冇話係咩時間會痛啲咁樣㗎？
有時朝早起身就痛啲咯，不過其實成日都會痛嚇。我扮咩咧？直情隻手咁樣開頭咁樣抽嘅，抽下，跟住我冇力，完全唔喐得啦嚇。我係完全冇試過。
想問你 抽嗰陣時咧，係咪個人係清醒嘅？
清醒嘅嚇，都好驚啊！我都嚇。
係淨係得一隻手抽咁樣。
係啊，隻手抽咯嚇。
個人
嗰一下個頭都
失去意識
痛嘅，嗰下個頭都痛嘅嚇。
咁頭痛嗰方面咧，會唔會話係瞓低就冇咁痛咁樣㗎？
瞓低嗱，我抽筋其實都快已經嚟咗醫院嚇。咁嚟到醫院嘅話咧，就似乎坐喺度就好啲嘅，即係姑娘教高我就好啲嘅嚇。
咁睇嘢嗰方面話有冇會視力模糊啊咁樣㗎？
睇嘢，你意思係即係點啊？睇嘢視力
即係差咗咁樣蒙啊，或者睇唔到邊啊咁樣嗰啲。
睇嘢呢輪都係蒙蒙地嘅嚇，我覺得即係有時望啲近嘢反而就真係差啲啦呢輪嚇。
好，即係都係同呢排先有呢啲咁樣嘅。
呢半年到啊，呢半年到啊，差得緊要啲嚇。唔知係咪老花咧？真係嚇。
咁我想問下咧，你除咗話今次震之外啦，以前有冇話有咩病痛咁樣㗎？血壓啊嗰啲有冇㗎？
血壓就冇喎嚇。咁其實不嬲個人都幾健康嘅嚇。
即係三高嗰啲都冇嘅。
三高唔知有冇啊，但係即係我冇乜唔舒服，咪唔去睇醫生咯嚇。咁冇人講過我有事嘅。我個身體感覺上都覺得幾好嘅嚇。感覺就冇乜嘢喎嚇，冇乜特別。塊面咧就我自己唔覺得咯嚇。
呢排有冇磅過重啊？有冇覺得自己突然輕咗好多啊？咁樣
輕咗少少啦，唔係好明顯咯嚇。我諗輕咗2-3磅嚇。
咁胃口嗰方面有冇差咗？
胃口都仍然可以嘅，冇問題嚇。
會唔會成日覺得個人好攰咁樣？
有時都會攰嘅呢度。有冇其他嘢問？緊要啦。So I think that just up to this moment, so you have asked what am I having the problems. So usually I've got a chief complaint. So what sort of complaint I'm having?
Your chief complaint would be the weakness of your left hand, and also you complain of some left lower limb weakness, which improves after since the onset.
Agree? Anybody has any? Now I do not agree with you completely. So now, of course, one of the things that brought the patient in is he has got the convulsion. So the convulsion may be one of the complaints. And then the second thing is he has got weakness after the convulsion. So according to the patient, the weakness is worse over the left hand, it's not over the left leg. And of course, later on, we can see whether there is an explanation for that. So he has got convulsion, he has got left-sided weakness after that, right? So if we just focus on a convulsion, what sort of convulsion that we are referring to? If the convulsion is true, if what the patient has described is true, what sort of convulsion he is having?
Some clonic seizure.
Some chronic seizure. Okay, you can have chronic, and then there are other types: tonic chronic seizures, absent seizures, some complex partial seizures. So right now, if it is a twitching, it can be chronic. So what will happen if the patient has got a tonic chronic seizures? So maybe there is an episode that he is very spastic and that he start to have some twitching. So that will be a tonic chronic seizure, or other. There's another name, grand mal seizure, for that. But to have a grand mal seizure, other than this twitching, you still have another component, which is the patient cannot be awake at that time. If it is a grand mal seizure, tonic chronic seizure, then the patient will have loss of consciousness at that time. So it's a seizure together with LC. So for this patient, he is having some twitching of one side only. And he has been telling you that he has been awake during the seizures. So what sort of seizure is this? Now, in seizure, we can tell there sometimes some is called complete seizures, some is called partial seizures. So for complete seizure, you have got LOC. So it can be tonic chronic grand mal seizure with the twitching, and it can be just an absent seizure. The patient just have a drop attack. He's just lost the consciousness, but no twitching. So that is also called petit mal. So it's grand mal and petit mal seizure. That are two complete seizures. And when the patient has remained conscious during the seizure, it is a partial seizure. So this is a partial seizure affecting the left side. So partial seizures. And then sometimes the patient might have some very strange component, very strange behavior, behaving very strangely, just like dream walking and so on, and behave like another person. So for that, sometimes it's called complex partial seizures. It usually happens when the patient has got a temporal lobe lesion, and then very strange behavior, maybe the patient having some strange taste, and then hearing auditory hallucination, and that sort of strange behavioral problem. So that is complex partial. And the complex, the issue, there is sometimes the focal partial seizures, and then generalizing to generalized seizures. So initially it started off with the left hand twitching, and then the patient became unconscious, and then the seizures is involving four limbs. So it's starting as a focal partial seizure, and then it is becoming a generalized seizure. So there are different types of seizures, different names. So for this is a focal seizure or partial seizures, in which the patient is conscious all along. And then the important thing is, if it is a seizure, what type of partial seizure it is, for you to categorize the patient or to work up the patient. Now for this man, 52 years old, according to he himself, he has been perfectly all right, or maybe it's more or less all right over the last few years. And then this is the very first seizure he has. So this is somehow different to a patient who has been having a seizure for 3 months already, or having a seizure for 30 years already. So this one is a late onset seizure. This is the first episode of the late onset seizure. Agree? So for this late onset seizure, first episode, this is a focal seizure affecting the left side. Do we have any other information for this seizure? For every seizure, you want to ask about questions. So what other questions do you want to know? Maybe just like a certain illness, a weakness or blurring of vision, you want to know how bad is that? And then you want to know, actually, is there anything that trigger off that seizure? So is there any event that trigger off the seizure? So far, I think nobody has asked, but you have to ask. If I presented with seizure, then I think you have to know whether there is any predisposing factor or precipitating factor. So what will be the predisposing factor, or what will be the factor triggering a seizure attack? Watching TV or browsing browsing the internet, is it going to cause seizure? 黃子軒 said no. But actually, yes, it's possible. And for some of the patients who are having migraine or having problems, a flashing screen and sometimes actually can trigger a seizure. So for these patients, they may not be able to go to a movie cinema. They may not be go to watch a movie, and sometimes they may be not able to work with a computer because they may be seeing flashes, and that is going to trigger off some seizure. So flashes, they can trigger some seizures. So what other factors can trigger a seizure?
Hyperventilation.
Okay, sometimes they are hyperventilating. They are very anxious, and then they are feeling stressed. Stress itself can trigger a seizure. So in examination, sometimes if they are very stressful, they can have a seizure. And hyperventilation, of course, or if you have some form of electrolyte disturbance, hypoxia, hypotension, I think anything can lead to a seizure. So what other things can lead to a seizure? Yes, good. So some medication, they can trigger off seizure. Some alcohol or some drugs, what you call recreational drugs or drug abuse, they can trigger a seizure attack. For this point is actually, if we are using anticonvulsant, sometimes they can also trigger a seizure. So medication, drugs, alcohol, they can trigger seizures. Yes. Any other things that can trigger a seizure?
Lack of sleep.
Okay, so tiredness, yes. And sometimes for the ladies, when they're having a period, they might be a weekend, they might trigger a seizure. So another thing is head injury. So if the patient is having a head injury before, then they can also have a seizure after that. So more or less, you have to, if the patient presented with a seizure, then you have to ask all these factors. Be it a late onset, the first attack, or the patient is a chronic epileptic, he has been having seizure for a long time, then you still have to ask. So if this patient is a chronic epileptic who has been taking drugs, so of course you have to ask every question, but what are the additional questions you want to know about? If it is a patient having chronic seizure and taking drugs. Yes, good. So you have to ask the patient about drug compliance. So somehow to check the drug compliance is just like doing a criminal investigations. So somehow you have to ask the patient what type of drug he is taking, and maybe you have to ask when is he taking, and then is he following the instruction and so on? Does he forgot to do so? And so you have to tell. Maybe you have to ask the one who is living with the patient, is he taking a drug? Is he lying, and so on? So somehow we have to mind about the drug compliance. So far we want to know whether there is anything that leads to a seizure. And then after the seizure, we also want to know about whether there's any complication for the seizure. So does this patient has any complication related to the seizure? And what is the complication? Okay, so the side that he is having the seizure have weakness afterwards. So is there a name for it?
Is it called thoughts paralysis?
Yes, thoughts paralysis. Yes. So for thoughts paralysis, it typically is weakness of the affected side after a seizure attack. And for most of the time, it's going to improve later on, very shortly afterwards. So we can assume he might be having a thoughts paralysis, or he can have some more serious problem. So we have to investigate how bad he's doing. So, and there is also one thing that might be happening when the patient is having a seizure. So if the patient is unconscious or somehow do not know whether he's having a genuine seizure, so you are worrying whether the history is correct or not. But he is telling you, I'm having a generalized seizure, and there is no witness around. So can you ask further questions to see whether he is just malingering or whether he's having some problems? If the patient is having a generalized seizure, what will be the additional features he might have?
Any post-actual drowsiness?
Okay, post-ictal drowsiness. Yes, he might be very sleepy after that. Yes. So let's say if I'm a very, very anxious patient, and then I'd like to come to see the doctor every now and then, and this time I tell my doctor I have a seizure, I become unconscious, I've got twitching, and then you somehow you are thinking, is he malingering or so on? Then you can ask about some questions. So to pinpoint it is, what I'm saying is a genuine seizure, but some of the patients are having so-called pseudo seizures, which is not a genuine seizure. So how to differentiate between a genuine seizure and a pseudo seizure? Now for the ordinary layman, pseudo seizure, I think, is still somehow a so-called seizure. It is not just a malingering, but somehow the patient acts like he is having a seizure. But usually there is some psychological gain with it. So it's not the typical seizure. So for a typical generalized seizure, he is grand mal seizure, loss of consciousness, and then the patient might have a fall. And because of this fall, he might injure himself. He might have a head injury, he might broke his leg and so on, he might broke his wrist. So, and also there may be urinary incontinence. So somehow the patient might be having a problem like that. But for pseudo seizure, so for pseudo seizure, most of the time we do not expect a urinary incontinence. And then the place where the seizure happens is, for the generalized seizure, it can happen anywhere. It can happen in the office, at home, it can happen when they are taking a bus and so on. But it can also happen when you're out in the streets, when you are crossing the road. So it doesn't matter where it is, and it might put you into extreme danger. But for pseudo seizure, a lot of times the patient, they are protecting themselves. So most of the time they do not have an injury. It usually happens when they are in a safe place. Of course, for a very clever patient who read all the things in the stuff in the internet, he might get all the signs and symptoms, and then somehow he may imitate it. But for the ordinary lay public, to differentiate the genuine true seizure and the pseudo seizure, usually the true seizure, they have incontinence, they can happen anywhere. The patient might be having an injury. For pseudo seizure, usually they are safe, they do not hurt themselves. So more or less, these are the things with the seizures. So of course, if the patient is having seizure, then you want to know what is the exact cause that lead to the seizure. We have some predisposing factor, but what is the exact cause for the seizure? So what are the things that you are thinking behind? I think you have asked questions about those causes, but let's discuss what are the causes that can lead to a man who is having a seizure like this. Then what other features I am telling you? I think your colleagues is asking, did I have any hypertension and so on. So if I have hypertension, what is the difference? See, hypertension and seizure, any relation?
We'll be thinking about whether it's a stroke.
Cannot hear you clearly.
We'd be thinking whether it's a possible incident of stroke.
Stroke. Okay. Yes. So if a patient is having a stroke, yes, it's possible. So you want to know about the risk factor for stroke. So what are the risk factors for stroke? Hypertension, hyperlipidemia. What are the other risk factors for stroke that you can ask about? Or diabetes, okay. Any other risk factor for strokes? Do you worry about a stroke for yourself? So if so, what are the features you worry that you hopefully want to prevent yourself from having a stroke?
Like smoking or lack of exercise.
Okay, smoking is a very important risk factor for stroke and other vascular disease. So of course, if you want to look upon stroke, you should ask whether the patient is having a smoking history or drinking history. Yeah. So be careful about some smoking history. When we ask a patient, sometimes 有冇食煙啊？patient 咪 said 我冇食煙啊，入嚟咁多日冇食煙啊咁 so that is not true. So you have to really ask about how long did you smoke, and if you quit, how long did you quit, and so. For drinking, is it a risk factor for stroke? Of course, doctors are not recommending drinking, but is drinking a risk factor for stroke? Not so factor. I'm not sure whether they are saying there is a protective mechanism for heart disease and so on, but anyhow, it is not a very bad factor for stroke, drinking itself. For drug abuse, I'm not sure. So you have to ask about, be it in the social history or if you really think about stroke, so you have to ask specifically on smoking and other risk factors. So lack of exercise is a risk factor. So what type of work he is working, and then of course is a sedentary worker, what is the body weight, and so and so. So you want to know. What other risk factor for stroke? Okay, yes. So past history that is suggesting he is a vasculopath. He is having heart attack, he is having PVD, and then he's already having an amputation of the leg. That is suggestive. But another thing not to forget is an old history of stroke. He has got a stroke before, an ischemic stroke before. And if you are going to ask about ischemic stroke, what questions you are going to ask the patient? Do you have a stroke before? You say, oh, I'm not aware.冇醫生話過俾我聽有中風. And are you satisfied with this? No, you will not be satisfied. So you have to ask further questions. Does he have a stroke before? What question you want to ask?
"以前有冇試過，例如係即係暈一暈啊，會即係面部肌肉會突然間喐唔到啊，講嘢會唔會亂，即係咬字咬唔到啊嗰啲？"
而家佢哋講啦，咩談笑用兵啦嚇，即係會唔會有一個 slurring of speech 啦？談笑就會唔會有 facial asymmetry 啦？用就即係唔識喐就 weakness 啦，兵都係行唔到、睇唔到嘢咁啦嚇。即係總之 somehow does he have a history of sudden onset of weakness, loss of speech, sudden loss of vision, facial paralysis. These are the histories suggestive of stroke. And of course, for stroke, there are two important elements. Usually, it's a sudden onset. 唔係慢慢嚟嘅 It's not a insidious onset. It should be all of a sudden. Just wake up and to find himself right side completely paralytic or cannot speak. So it's a sudden onset. And then he can get improved later on, maybe minutes later or 2 days later. So somehow they can have some improvement later on. And also for stroke, there is a similar condition which is related to stroke. That is very important to us. It's called transient ischemic attack, TIA. So for TIA, the patient might be having a transient hemiparesis. 突然之間喐唔到，但係跟住好快啦。He can move himself 3 hours later, 4 hours later, completely normal right now. That is transient. The definition of TIA is the deficit improve or become normal within 24 hours. So it can be a sudden loss of vision called emerosis fugax. It can be a dysphasia, aphasia, facial asymmetry, weakness of one hand or one side, or so on. So you have to ask, is there such a history of stroke? So these are important for stroke. And then the history, and if you are asking about stroke, we have two types of stroke, ischemic stroke, hemorrhagic stroke. From the history, usually can you tell which is which? So right now I'm saying, okay, this time my left hand cannot move. So a doctor, the A&E doctor said, I have got a stroke. And then you are the houseman or you are the medical officer. So besides getting a CT scan, so you have to make a choice whether you want to give those TPA and then whether you want to give him aspirin and so on, or whether you want to consult the neurosurgeon. So you have to make a choice whether it's an ischemic stroke or hemorrhagic stroke. So any difference between these two in the symptoms? Now, for most of the ischemic stroke, it involves a little territory, the small territory. So most of the patients, they remain conscious, except in the very widespread area of ischemic stroke. So coma itself is not a feature for ischemic stroke, whereas coma is more common with hemorrhagic stroke or in impaired conscious level. And then, of course, if you check the pupils, for a dilated pupil, it can either be a very bad hemorrhagic stroke or very bad ischemic stroke. And then for his hemorrhagic stroke, patient might be having severe headache at that time when he's having a bleeding. So headache, LC, they are more pointing towards a hemorrhagic stroke. For ischemic stroke, usually it's just the deficit and the patient remain conscious. So you have to tell which type of stroke the patient might be having. So stroke is one possibility. And does it sound like stroke in this case? So I can see Wang Zihim said no. Why is no? Why do you say no? It can happen for stroke, but for stroke, in this man, he has got a seizure, and after the seizure, he has got weakness. So more or less, it's triggered off by the seizure itself. And does he have any weakness before? I think it's very ambivalent or very fake that apparently he's not having a very bad weakness before that. So most of the symptoms start after the epilepsy. So still, it can be some stroke-related problem. It's sudden onset. So sudden onset is very important. So it can be a stroke. So any other possibility is suddenly he is having a seizure and then he cannot move. Can he have a tumor? Can he have a brain tumor? So this is Philip. Philip said yes. Can he have a tumor? Yes. Why can he have a tumor?
I think it's because a tumor can interrupt a more focal, can give rise to a more focal type of seizure, and the weakness is more likely to do with the seizure itself.
Yes. So I think your point is taken. One of the symptoms for tumor is seizure. So anyhow, whoever can have the first attack of seizure. So tumor itself can present with seizure. And as he said, for the seizure itself, it can be a focal seizure, it can be a generalized seizure. So both is possible for tumor. But of course, it is not very typical of the seizure of the tumor. So far, I think there isn't much symptoms about that. So there isn't much weakness before this episode. And I think I just add some symptom for you. I've got some headaches for 1 or 2 months and so on. So this headaches is more severe in the morning, and this is just try to act like see the tumor. So why did the patient have more morning headache in tumors? So morning headache is a peculiar thing for tumor. Why did the patient have morning weakness, morning headaches?
Because of raised intracranial pressure.
Okay, for raised intracranial pressure, during sleep, our control is not as good, so carbon dioxide might build up. So somehow they may be causing more vasodilatation and more blood flow into the brain, and then ICP is further increased. And as well, the patient is lying on bed. So somehow lying on bed, venous drainage is not as good. So also ICP is higher. So usually for raised ICP, it will be improved when the patient is in an upright position. So just like the fluid, the water, they drain to the feet. So the ICP will improve. So one of the treatment for raised ICP is we just prop up the patient and sit up the patient. So this thing might be some feature of a tumor, suggests if something is wrong, but we cannot be sure. Of course, if the patient is really having raised ICP, besides headaches, what other symptom would you expect? Vomiting, okay, nausea, vomiting, convulsion, maybe other signs like facial asymmetry, weakness, blurring of vision, hearing problems, whatsoever you can think of. So he might be having all these problems. And I think your colleague has asked about any weight loss. So what does it mean? Weight loss, what is this? Why is she asking about weight loss? This is Kok Wing Yi. You asked me about weight loss, is that right? Why are you asking me about weight loss?
I'm thinking of the possibility of any malignancy.
Any malignancy. So it can be somehow the systemic inquiry, or it may be relevant to this case. if it is really having a tumor. So the patient might be having weight loss, he might be loss of appetite, loss of energy and malaise and whatsoever. So you have to tell. Usually for systemic inquiry, you have to ask, and it's also relevant in this case. So I try to make it maybe relevant. So not very significant weight loss, but some weight loss. And okay, so after all these, what other forms of infection or not infection? What other causes of seizure can you think of as a differential diagnosis, or you have to ask in your history? Yes, I have a Freudian slip. I give you. So if the patient is having meningitis and encephalitis, they can have a seizure. So I'm not sure if you are right now, if you are having the COVID vaccination and then somehow a patient come in with a seizure later on, can it be related to the vaccine? Yeah. I'm not sure, but it can. If it is just inactive attenuated virus, somehow can it trigger some infection or some very mild inflammation of the CNS? Still, it can be possible. So infection, inflammation, vasculitis, they can give rise to seizure. And trauma itself, they can give rise to seizure. So a lot of stuff, metabolic causes, they can give rise to seizure. So I think in this sense, maybe more or less we cover this patient. So he has got the first episode of seizure, which is a partial seizure. And then he has the complication, apparently the thoughts paralysis after that. So we try to look into the causes of it. Maybe he's having some weight loss, and then he's having some headaches, but otherwise quite well. He's still walking around, talking around. So here comes it. And do we miss anything from the history? Will the family history be important? And why is it important? So if the patient has got a brother who is also having a seizure, or his father is having a seizure, then might be they are having a similar underlying cause. But other than that, for the seizure or the tumors, most of the seizure and tumors, they do not have a familial inheritance, except some specific syndromes. Otherwise, they do not run in families. Yes. So So in this one, if you are going to examination, you are going to ask Dr. Paul to do the examination for you in Zoom. So what would you direct your intern to do so? Or I'm right now, you are the neurosurgeon, I'm the physician. I'm going to consult neurosurgeon. Okay, Dr. Ho, you are the neurosurgeon. Right now I'm the physician, Dr. Paul. I have such a patient. I do a scan. Before the scan, would you want to ask me anything about the patient? You cannot examine the patient right now, and you have to ask me to do the examination. What signs do you want me to know, to show?
Some focal neurological signs.
Neurological exam.
Neurological exam.
Okay, so far, what tests you want me to do so?
Neurological exam. I would like to test for the limb power and also the sensation.
Okay, you want to know the limb power. Right now, we'll say the left side is weak. You said the left hand is weak. So left hand and maybe power is around grade 2. Left lower limb is grade 4, and right side is grade 5. Are you happy with this? Maybe. And because actually we can go further on. It's actually for this patient, even for his left upper limb, the proximal side is grade 4, actually grade 4, and the distal part is grade 2. So sometimes even for the same limb, they have a difference. So if you spot such a difference, or if you think the disease is going to affect different parts differently, then you have to go, you are not only satisfied with a left upper limb as a whole, just by grasping the finger. You're not just doing this, you have to test proximal, distal. If you are thinking about spinal cord problem, you have to go individual myotones, C5, C6, C7, C8, T1. You have to go along all these. So, okay, right now, left upper limb is weak. So hyperreflexic over the left side. And then the plantar response is upgoing on the left side. So are you happy about this physical exam? Sensation. What sensation you want to test?
For proprioception and also pain.
Proprioception and pain. Okay, for pain, how are you going to test for pain in a patient like this one? Okay, we have some needle pins. We have some pins. Okay, I've got some pins right now. Let's pretend I've got a pin. So how are you going to test the sensation? Let's pretend this is a pin. Oh, this is a paper clip. So how to poke it like this one to test for the pain?
Follow the dermatome.
Oh, dermatome. Okay, that is very serious. So you are going to ask about C5, C6, C7, and then you're going to do a lot of tests. So usually, of course, you have to ask to test the pain sensation in the neutral area. Okay, you expect normal sensation, maybe over the trunk or over the head. So you have to demonstrate to the patient. Okay, just can you feel the pain here? Can you feel the sharpness? So you have to demonstrate to the patient first. What do you mean by pain? And sometimes I also try to use the needle side and maybe the other side that is blunted. So I just show them the difference between the blunted end and the needle pinpoint. And right after that, you are going to test him. I would like to test him on the normal side first. So make sure he knows what is that, and then test on the normal side. Then you decide on which distribution you want. Whether you want to test just on the one hand, or as Ivy has said, from C5, C6 downwards. It depends. And also if let's say the patient is having a Erb's palsy or brachial plexus, then you are going to test on the individual nerves. For DM neuropathy, you want to test on the peripheral, whether there is any glove and stocking sensation. Maybe it's lost over here, and then somehow it's getting better over the more proximal aspect. So you have to test pinprick. Okay, proprioception, just test it, make sure the patient understand what you're meaning. And what other modality you want to test for sensation? Then pinprick is common, but proprioception is not the common thing we usually test first. The common,
Is the cotton wool for testing fine touch sensation?
Yes, usually we test light touch and pinprick. These are the common things that we use. Or maybe we use a cotton wool or just a scores to test on the light touch or pinprick. And then we can, for some conditions, we test the proprioception and temperature sense and so on. But it's very tedious for sensory. Apparently, maybe this patient is normal. So what other tests you want to do? If you're a student, of course, you want to do head-to-toe examination, but this is very time-consuming. And I can tell you that most medical officers, they don't do the complete test. Now, motor sensation, of course, you want to know about the cranial nerves. Okay, whether there's any extraocular movement problem, whether any squints, any ptosis, facial asymmetry, hearing problem, vision. So for vision, you want to know about visual acuity. So you have your Snellen chart in your phone right now. You can test him on the visual acuity. So if you are testing the visual acuity, should you ask the patient to take off the glasses? No. So you ask the patient to wear the glasses he is wearing, and then the test the VA. Maybe on one side, right side, left side. To complete it, of course, you want to know about visual field, color vision. But finally, if you are testing the vision, you have to use the ophthalmoscope to look into the fundi. For hearing, a lot of times we do not test for it, but just somehow the patient might say, I'm deaf on this side. So if the patient is deaf on one side, you have to think seriously, is the deafness related to his disease? So it's important to know. So you have to do this test. So after all these cranial nerves, motor, sensation, reflex, what else are you going to look for? Okay, gait, cerebellar sign, you should not forget about this thing. And for some particular case, if you're really thinking about spinal cord pathology, you have to go for anal tone. So usually, of course, we do not do it lightly, but for some cases, you should do this anal tone. So more or less, after all these tests, apparently, this patient is maybe just like me, a little bit fatty and then a little bit obese, and somehow he has got the weakness on the left side. Otherwise, he's quite all right. So let's see some of his picture. I'm going to see. Let's see some of his picture. So we did all the basic blood tests. So CBP. What sort of information we want to know about from a CBP in this man? Okay, good. Okay, yes. So we want to see is anemia significant? Is anemia important in this case? If the hemoglobin is abnormal, is it important? Yes, it's important. Usually for the basic stuff, first of all, you want to know whether he has got the cause is reflected by the anemia and so on, whether there is a cause of the disease. Or on the other side, if we are going to do surgery on him, whether he is fit for surgery. So it's the same for platelets. Okay, I want him to have a normal platelet. Both sense. He's not having thrombocytopenia to cause a hemorrhagic stroke, and also he is fit for surgery. Where is, yes, this is this man. So we did have some CBP. CBP, the hemoglobin is 13 point something, white cell, one is 11, one is 8. This is a bit high. Platelets normal. Yes. And then we have the, we want to know renal function. Okay. You can see some red things. So is it important in this case? The red thing. Now renal function, sodium normal, potassium, urea, creatinine all normal. But somehow for the liver function is somehow is abnormal. 32, is it important? Usually not that important. 39, is it important? Globulin. No, maybe he has got some liver disease that leads to a reverse AG ratio, but not very important or alarming to us. Bilirubin of 4. Alkaline phosphatase 135. ALT of 74. The range is so this 135, is it important? Now these two, actually I would say these two is a little bit alarming for us. So although 32, 39, I think we usually would ignore it. So it can be something wrong with the liver, or it can be something wrong with the bone. So it's not too high, but it does raise some suspicion for us. And then the PTA, PTT clotting is normal. It's a little bit prolonged, but not significant. And then glucose is quite normal. He did not have any COVID and so on. No significant infection element or culture. And somehow we think along tumor, so we check a lot of these tumor markers. So the tumor markers is the PSA. What is PSA? Okay, so we want to know whether he has got CA prostate. So that is normal. Now this one is normal, PSA. CA 19.9, I don't understand why, what is this? But somehow this one is grossly abnormal. CEA 8,000. And then alpha fetoprotein for liver tumor is normal. So what does it mean? This CEA usually is a single digit one. And then right now he's 8,000. It is one of the highest CEA I have ever seen. So what is the significance for this? So of course he might be having cancer. So what sort of cancer will have a raised CEA? Adenocarcinoma. So any common adenocarcinoma? EA colon, yes. And the other common thing is CA lung. Yeah, so this is very highly suggestive of a cancer. But of course, in a lab, it usually did not issue at once. It may take 1 week to have this blood result. To us, the alarming thing is somehow he has got a CT scan at that time. CT scan, yes. So of course, neurosurgeon, we will concentrate on CT, on MRI and other imaging. So somehow this is a plain CT, non-contrast CT. So we haven't seen much in this scan at this moment. Looks quite normal. It's starting to be abnormal here. So there are a few nodules. How should we describe these nodules? What is the term for this nodule, the description of these nodules? I think everybody wants to order a CT and MR. So this is a trend. But we have to know what to look for and how to describe it and how to write it down. If we ask for all the CT scan and we don't know how to interpret, then of course we are just putting ourselves in deep trouble because the scan is going to last forever, and the lawyer will be very happy for this. So there are 3 nodules here. So of course we want to know the size, maybe less than 1 cm. Okay, how should we describe this? What are the characteristics of this nodule?
It's hyperdense.
Yes, this is hyperdense. Okay, we use the gray matter to differentiate. So anything that is hyper than the gray matter is hyper. This thing is hypodense, it's dark. So there are 3 hypodense nodules in a non-contrast scan. And if you go further up, there are more nodules, some of which are even more hyperdense. And surrounding them is a hypodense area. So apparently what we can see is this is the right side, right cerebral hemisphere. Maybe it's the frontal lobe. It's the frontal lobe. There is a lot of just hyperdense nodules surrounding by hypodensity. So it can be a stroke, it can be hemorrhage, or it can be some tumors, or maybe some bleeding tumors. So this is an impression. Another differential diagnosis, which is actually made by the referring physician, is can it be an AVM that has bleeding? So I think maybe it's still reasonable to think about that. AVM or vascular lesion along the trend of bleeding. So somehow there's some lesions over here. So we think actually at that time it's more likely to be some tumors. Of course, AVM, other things are still possible. But what tumors? So for tumors, how to differentiate brain tumors? Now, of course, in the medical sense, knowledge, how can you categorize brain tumors? Not as a neurosurgeon. Can you give some differentiation between brain tumors? Yes, good. Primary and secondary. But before that, yes, primary. Okay, primary. Any other classification schemes?
Intra or extra-axial.
Okay, the location intra-axial is inside the brain, extra-axial is outside the brain. It can be in the bottom, in the skull base. It can be somehow, because of the 3D, it can look very strange, but outside the brain or inside the brain. Primary or secondary. And then benign or malignant. It's important. Benign tumor like meningiomas, pituitary tumors, malignant tumors. Malignant tumors, it can be primary, it can be secondary. Primary, glioma, glioblastoma, germinomas, that sort of tumors. Secondary is metastatic brain tumors, cancers. But we still have one group of malignant tumor to think about. Sometimes the hematological malignancy, they can spread to the brain. So lymphoma, they can spread to the brain. And lymphoma can have very funny appearance. Actually, in the very first scan, one of the differential we think about is lymphoma because it looks a bit quite strange to us. We usually we see one tumor, but we usually do not see so many small tumors. So we bear in mind that actually could it be lymphoma and so on, because the treatment is different. For lymphoma, the mainstay is chemotherapy, radiotherapy. And neurosurgeon's role is maybe we get a diagnosis, we get a pathology for them, and then we leave it to the hematologists and radiologists. But for metastatic tumor, sometimes we also remove the entire tumor, or sometimes we just refer the patient to them for chemo or radiotherapy. So we think there are different possible malignant tumors. So we asked for further imaging. What sort of further imaging you can think of? Now, bearing in mind right now in the HA hospital, you book any sort of investigation, usually it takes time and you have to talk to the radiologist. It's just like begging the radiologist for an appointment. So we want to be exact, we want to hit the right goal. So right now with this scan, what sort of investigation you want to ask? I'll show you another scan, okay. Show you, yes, the simple thing that we have, chest x-ray. Because if the chest x-ray already show up multiple nodules, then we can be pretty sure that it is a metastatic tumors. So this scan is actually looks quite normal to us. So doesn't give any additional hints to us. So we can either go for a contrast CT scan or MRI scan with contrast to look more exactly in the brain lesions. And because of the tumor, we also suggest the patient can he go for a PET scan. A PET scan is actually a screening, it's a PET, the radioactive isotope, those metabolic activities coupled to a CT scan. So in the, actually see, this is a CT scan, MRI here has got anyhow 12. So right now we have got several series. Let's see. Yes. Okay, maybe this one first. So we are all looking towards the axial scan. So this scan, what we call is this is a flare sequence. Oh, I should not show it to you, this one. I would like to show you this one instead. Yes, this is T1. T1 to us is just like a black and white photo. So you just like having a brain cutting into pieces and then they're showing up in black and white. And CSF is black. And then this is white matter, gray matter. So there is apparently this lesion that we have seen in the CT, and the extent is more clear to us. And to couple with this, we can ask for the T1 with CTs with contrast. So this is a contrast. So what you can see is the lesion is actually what we call enhances. So without contrast, it is a little bit hyper. This time is called intense. But with contrast, it stands out in white. So we can call this one, this lesion is enhancing with contrast. But actually, to our surprise, we think there is a couple of lesions over here. But actually, when we look in this CT scan, you can see it is not very alarming on here, but on the contrast scan, it's very alarming. So maybe there is one dot here, and then to our surprise, there is actually numerous enhancing dot in the cerebellum. More than 100. And we did look back in this scan, it's actually not shown up well. And in the CT scan, it doesn't show up too well. So it can still be multiple lesions, multiple enhancing lesions. So it is pointing towards a metastatic brain tumors. So the other scan is, this is called T2. It's just like the film of T1, it's inverted. So in T1, the CSF is dark. In this one, all water content is bright. So water here is bright, water here in the subarachnoid space is bright. Here, we think this is due to edema. So it is intracellular. This is a cytotoxic edema. It is still white. And somehow, if we want to differentiate, is it CSF or somehow edema, then they have another sequence called the flare sequence. Yes, so in which it's just like basically it's a T2, but somehow for all those CSF moving CSF, they just make some changes, it appears dark. But for the edema, they become white. So the difference between what we call a T1 and T2, sometimes the changes are more drastic in T2. So actually to us, this T1 is just like an anatomical picture of the patient's brain. Just like the section, you cut open and then it appears like that. But for this one, it looks like the pathological specimen. So it tells you the pathology, not only this tumor, but somehow any other region that have a lot of water, which is problematic. So we want to have a lot of sequence. So this mainly for structure, this is for pathology. And then they have really right now a lot of sequence. This is for vessels, sometimes showing the bleeding, and then for blood products, they are stand out like this. So of course, in MRI, you can have 3D. You can have 3D, that is, the lesion is in the right side frontal region. And then a lot of numerous enhancing spot over the cerebellum. And you got sagittal cuts. That's more or less showing the similar stuff. And sometimes they are doing angiogram for this one. They've got stroke package. So we just do the angiogram. It's not going to produce any form information for this. So alarm right now is quite alarming. And as well, the patient has got a PET scan as well. PET scan. I'm not sure whether I can show you the PET scan. PET scan. I try to download it, but it takes a lot of time. So actually, I just tell you the report is there are lots of abnormality in the PET scan. There are lymph nodes in the left neck, lymph nodes in supraclavicular region. There is a nodule in the right lung. There is lymph mats. There is retroperitoneal mats. There are bone mats. So far, apparently carcinoma everywhere. So with this, summarizing this information, we think it might be having a primary CA lung, and then it's spreading all the way. The high ALP is signifying either a liver problem or a bone problem. And then he has got a lot of brain metastasis. And some of these brain metastasis has evidence of bleeding before. So to sum up all these is the patient is having a silent cancer, actually widespread, spreading to everywhere. And what causes seizure is, of course, there's got underlying tumor that can cause seizure. But apparently he has got a bleeding. The bleeding might have triggered a seizure, and then somehow a thought paralysis, and maybe somehow it also worsening the power on the left upper limb. Oh, this one. No, this is not. This is still MRI package. I want to see the. So maybe I cannot show you the PET scan, but there are tumors everywhere. To actually, to our surprise, we expect it's maybe a single tumor and there is no primary evidence, no primary disease elsewhere. But when he come back with this, I look back, actually I feel the neck, there are some lymph nodes, there's some liver hepatomegaly. So actually this reminds us, we are relying a lot on technology, on imaging, on tests, but we are not doing good enough for ourselves. Actually, if we pay more attention on palpating the neck, on palpating the liver, actually we might be able to make the diagnosis earlier on. So as a future doctor, I think you have to learn in both ways. You have to get knowledge to know the advances, okay, in a carcinoma, in a metastatic brain tumor, what sort of tests you are going to ask for and how to interpret it. But on the other side, you have to rely on some basic stuff. And this is my pledge for all of you is, be a future doctor. You are not going to just distribute your things out to the physiotherapists, to the dietitian, to the radiologist, to whoever, but you have to make yourself valuable. Otherwise, the system is not going to rely on you, and then you can lose your job. And AI is coming in, they are reading chest x-ray better than me and you. And then in future, the radiologists might not be able to have a job. AI is better than them. So for us, I cannot remember the entire Harrison. So sooner or later, the knowledge base itself, there is an AI coming out, there's a chatbot coming out, just input the symptom, jaundice, and then they are going to ask you what other investigation, what other symptoms they have. And then with this, you have a 55% chance of having a liver tumor. So you have to actually, to combat with the AI, you have to get knowledge. You cannot be as knowledgeable as the AI, but you have to have your sense, your clinician sense. And of course, I think the doctor is not going to lose a job, because Google itself is not going to make a digital surgeon. He is not going to make a surgeon who had cut and then who is going to make complications. And somehow the patient is going to sue Google for wound infection. Google is going to make a surgical robot for you or for me. Later on, he makes me carry out this order, and then the liability is with the human surgeon. It's not with Google. So I think for those who are still working on it, still treating the patient with our hands, with our mind, I think we still have our job 30 years later on. But if you just rely on picking up the things, detecting things, and then knowledge, sooner or later, the AI will actually be much better than you and me. So you have to have developed your clinician sense. Later on, of course, you also have to be responsible for your family, be responsible for your friends. Of course, you can say, right now for this man, he has got headaches, so let's do a CT scan, let's do an MRI, let's do a PET scan, and then in HA hospital, you are going to wait 3 months for it. Maybe you should go to private and cost you $20,000. So are you going to just ask your friend to pay $20,000 for every symptom they have? They said, you're a doctor. I'm just having some minor headaches. You are asking me to pay $20,000 for a scan. So you have to have a balance on it. In this case, it's demonstrated the patient have widespread cancer without much signs and symptoms. But somehow, if we are diligent enough, we should be able to find, at least to find some. So I hope that I can share this case with you, make you think and make you feel interesting about it. So do you have any question for me? If no, then I overrun for 20 minutes. Let's say bye-bye. Okay, bye-bye.
Thank you.
Bye-bye.
Thank
Thank
you.
you.
Bye-bye. eating control, stop sharing, leave,